Let's talk about shock. What is shock? Oh, come on, y'all.
When the organs are shutting down.
Which one? Which organ? The kidneys shutting down. So shock means
The kidneys are shutting
I'm
down.
going into my Zen pose because y'all already starting to piss me off. Okay. Okay. So the word shock means your kidneys are shutting down. And then the word in front of it is how we got there. All right. So let's walk through basic fluid balance so we can just get it over with. And then we know for the whole shebang. A?
Yes.
A. All right. So something really bad happened to your body. So your body said, it did say something is wrong. You said it different than you've ever said it.
Really?
Yeah, no, that was wild. That threw me off. All right. So something is wrong and you're going to
Compensate.
vasodilate, which leads to increased capillary permeability. And then you're going to leak into the third space. So, and when a patient's in shock, their blood pressure is very low. That's right. And then your body has to make some decisions. And what's its first decision? It's going to have to pull away from the extremities. So that means, what are your arms and legs? Because you don't have to have your arms and legs to survive, correct?
Yes, correct.
What a day to be alive, but huh?
Cold.
Okay, they grow cold. Okay, so they're going to get cold. What else are you going to see?
Reduce cap refill.
So increased capillary refill.
Yeah.
Okay, so increased capillary refill. Girl, we need to do over. Okay, modeling. Pulses are going to be weak, right? Okay, and that is called, all those things together are called, you got this and I believe in you. So something we learned in first semester and then again in second semester, and then we went ahead and did it in third semester, and then here we are again. What that is, what, y'all, stop it. Y'all just told me shock is kidneys. This has nothing to do with that. Okay, so if I went up to you, we're nurses on the same unit, right? I'm like, hey, just want to let you know your patient in there, his pulse is super weak and thready, his arms are cold, he's modeling, he's got, thank you, she's new. Oh,
Like you were asking for.
signs of poor perfusion, right? So you're gonna have signs of poor perfusion. So you're gonna see that in every single shock that we talk about. Yeah.
Yeah.
All right. So that means that the blood has now shunted central. Thank you. Good job. That was very good. I'm proud of you for that. So it shunted central, right? Because it wants to give blood flow to
Brain, heart, and lungs.
boobs. Because I thought you were gonna say that. Okay. Anyhow, so it does that. And then it still runs out of blood because your blood pressure at this point is probably like 80/40, right? Because where's the blood? And the fluid is in the third space. So is there a lot intravascularly?
No.
No. So then what's your body going to do?
It's gonna take it away from the kidney.
Oh no. So when it takes it away from the kidneys, I mean, oh no, in a good way. When it takes away from the kidneys, that is called shock. And then what happens after that? What's the next decision?
Start taking away from more organs.
Yeah. Like, okay. Yes. So we're going to start taking away from GI and liver and all these different places. And that is called, and then they,
Die.
oh my God, good job. Okay. So that's why we get shock on death. Yes.
Yes.
All right. So let's do it. Shall we? Now we're going to go to the different stages of shock because we haven't really done this before. You should know them, but now we're just going to give a name to them. Okay. So everybody that starts going into shock at first, your body's going to be like, I got you, girl. And you're going to go, everything's going to, yeah, and compensate and do all of this. And then, oh no. Yeah. Okay. So that's what we're going to look through. Okay.
Okay.
So we preferably would like to get them before they get to the shock mods death part.
Yeah.
Okay. So stages of shock. Are we ready? Number one, compensatory. Guess what happens in that one? You're compensating. I'm so proud of y'all right now. Yeah. Y'all are so ready to be nurses. Okay. So this is your initial response. Your body's like, oh, holy crap. Okay. Now, even though you will, remember, you initially are going to vasoconstrict right as things are happening because something horrible happened to your body, you're going to immediately go into fight or flight, sympathetic response. So everything's going to start going up and then it's going to tank. Yes. Okay. So in compensatory, we got a sympathetic response. So your body's producing what two hormones?
Cortisol? No.
Okay.
Epi
Epi and norepi, which is also called levofen. You asked me straight up and I was like, yes. No.
I know.
Yes,
that.
it totally is.
I totally thought it was.
Yeah, I was like, yeah, it is, because I knew. And then I was like, no, that ain't right, girl. My TIA was like, eh. So yeah, that happened.
Did you see it in the recording?
Yeah, I saw a lot of things in that recording that was like, why did y'all come here? Because that was my worst day. Anyhow, so epinephrine and norepinephrine are going to be increased, right?
Yeah.
Okay, so we're pumping those out because your body's like, compensate. Yeah.
Yeah.
What's your cardiac output going to look like?
Low.
Stop it. You stop talking today. You're in a sympathetic response. It's going to increase your cardiac output. It's going to increase your blood pressure all of a sudden because this just happened. Yes?
Yes.
Why are you mad?
But I thought you were tacky, so that would decrease your cardiac output.
Well, you are tacky, but it's not, you shouldn't be so tacky to where it decreases cardiac output. But you also, when you go into sympathetic response, you increase contractility,
Okay.
right? So cardiac output at first should be increased. That's one of the purposes of fight or flight, is to give you enough cardiac output to run.
Okay.
Now they're not going anywhere. They're having a bad day. Okay. So heart rate's going to be respiratory rate. They're going to be sweating.
Yeah.
Blood pressure. Stop it. We're still in compensatory, boo-boos. Okay. So massive fight or flight. Yeah.
Yes.
Okay. So what am I going to do for the patient at this time? Can y'all just fix their problems and let's just get on with it? Or okay, sure. Assist them. You can't go wrong with that. Okay. What is the type of shock we're talking about? I don't know. It could be anything. You got to fix the problem. So I need to find out what the problem. Damn, this person's going through a massive compensatory. Something is really bad. Is it sepsis? You're going to do a workup basically at this point. Is it cardiogenic, right? Is it anaphylactic? And you should be able to pick that out pretty quickly, knowing what the patient came in for. I mean, if you had a patient that was admitted to the unit with pneumonia, it's probably septic. Yeah. If you had a patient that came in heart failure exacerbation, it's probably cardiogenic. You had a patient that came in with a peanut allergy. It's probably anaphylaxis, or maybe they're on vanc, or like, you'll have to know like your big things you got to kind of look for. Yeah. So you should be able to identify that pretty quickly. Then after you find the cause, now we need to hit it. Yes. Now we're going to start IV fluids because they're about to tank on you, right? So even though the blood pressure is high, it's not because they have too much volume. It's just because their body's trying to, and you know, it's about to. I'm just doing noises today. That's all I'm going to do today. All right. Monitoring their temperature at this point is very important, because you'll know as they start to go into shock, their temperature either goes very high or it's going to go very low. Do you understand? If it's septic shock, it's probably going to go high, right? If it is anaphylactic shock, that's a massive inflammatory. So I would assume it's probably going to go up a little bit before it tanks on you, right? Yeah, no, yeah. All right. So goal temperature at this point, 36 to 38. We just want them to be like normothermic. Okay. Well, we didn't fix the problem, because usually by the time you're close to going into shock, we may not be able to fix it. We can try, right? But at that point, like, something bad has happened. Yes. All right. So the next stage is called progressive stage. Guess what happens in that one? You progress into worseness. Okay. All right. So you're still trying to compensate, but at this point, your organs are like, this doesn't feel right. Yeah.
Yeah.
Yeah. So in the progressive stage, your systems are starting to fail. You tried very hard to compensate. Some of it's kind of working. Some of it really isn't. Okay. You with? Okay. This is the stage where you massively say, something is wrong that I can't fix. And now you're going to vasodilate, which is going to cause increased capillary permeability. Their blood pressure at this stage is going to tank. Do we understand?
Yes.
Okay. At this stage, you're having to pull a little bit of blood from all of your organs. Really, you're not in mods yet, but it's like, hey, I can't give you full-fledged like support, right? So you may start to see things like a little bit of altered mental status because your brain isn't getting like full. Thank you. Full perfusion. Okay. What are they going to look like at this stage? They look cold. Okay. Say it in a different way. If you were to look at this patient and just be like, oh, what would you see? Why are they pale? Why did you say that? Where'd you get that from? Oh, you just guessed it. Okay, cool. So where's all their fluid?
They're gonna be edema.
Oh, can you give me the actual name for edema everywhere? Thank you. Ironic that you got that answer right. So that is called anasarcus. They're going to look very puffy, but are they in fluid volume overload? No, they're actually in fluid volume deficit. Okay, now it's y'all's turn to have a bad day, because these are very simple questions. Yes? Okay. Peripheral pulses. What are they going to feel like at this point? Weak, thready, or they may even start to become like, oh my God, I don't know if I can really palpate something. What's going to happen in the bowels?
Hypoactive.
Very hypoactive. Sometimes they may even be absent, because your body will pull away from your gut in a heartbeat. So it's like, you don't need it, because you can take out a huge amount of bowel before you'll actually like be deceased. Yes. Okay. What do you think urine output's going to do at this point? It's going to decrease. That is called
Shock. Urinary retention.
Y'all. No. Oh my God.
I don't know.
Are y'all joking?
Not retention.
Their urine output's going to be decreased. They don't have retention. They ain't got no fluid in there. How can you have retention? Thank you. Oliguria.
I didn't know that's what you were asking for.
Low urine output. You didn't know that's what I was asking? Okay. pH may start to be affected at this point because the kidneys are starting to be affected once one of the kidneys' main jobs.
Acid-base balance.
Acid-base balance. Thank you so much for showing up today. Okay. So do we see what's happening? At this stage, you probably still have tachycardia because your heart's still trying to like, I'm gonna keep going. Okay. But everything else is probably starting like, meh, meh, meh. Do we understand? What are you gonna do? What's the first thing you want to do for this patient? Fluids. Second thing.
Fix the cause.
Yeah. Yeah, we can fix the cause. But they may also need
Pressors.
pressors and maybe albumin, depending on what's going on. If it was like cardiogenic shock, I probably would not give albumin, right? Because you don't want all that fluid in the vessels either, do you? But septic shock, that would be a good idea, right? Because we need fluid in the vessels and their heart can handle it. You understand what I mean?
Yeah.
Okay. So at this stage, because your body's like, look, I have no more resources. You have taken everything that I've got. It's going to switch to anaerobic metabolism. What is the byproduct of anaerobic metabolism? Lactic acid, which is why we run a lactic acid at the bedside. These are very simple questions. That's why you run a lactic acid. And that tells me this patient's starting to go septic. That too. So, okay. So we're going to do massive IV fluids. Okay. Remember, you always fill the tank before you press it, right? So we're going to do fluids and then pressors plus or minus albumin, depending on the situation. Y'all with? Cool. We're going to really watch that urine output. Yes, because at this part, at this stage, a daily weight isn't going to do me any good because they're in ICU and critical care. Do you see what I mean? So I'm going to have to keep giving fluids until we get adequate urine output, which is 30 mils an hour for adults. Do y'all understand?
Yeah.
Okay. All right. We need to start at an A line because I need to know if they're acidotic. So what I'm going to do if they're acidotic, we can, yes, you can give bicarbs. Sometimes that will work in ICU. Sometimes it won't. Really, the only way you can get rid of acid is to pee it out. So if we can flush them full of fluids and get their kidneys perfusing, then that should fix the problem. A Hail Mary, yes, we can do sodium bicarb. Sometimes it works. Sometimes it doesn't. But I mean, they can't get any more near dead at this point. Yes. Okay. At this point, when they start getting a buildup of lactic acid, all their organs are sitting in acid. So they may need to be vented at this point. They may not be able to breathe well on their own. Okay. Or to acid base balance. Because that's another way we could help get rid of the acid, right?
Yeah.
Okay. So if you vent a patient, that's helping them get rid of CO2, which is a acid. So that can help fix the acid base problem as well. Do you understand?
Yeah.
If the lactic acid is greater than this, they have sepsis. 4. If it's greater than this number, you need to recheck it. 2. It's okay. It's okay. All right. Do we understand the progressive stage? Yes. Yes. All right. Let's go to refractory stage. I don't like that word.
It's kind of weird.
It doesn't tell me anything. What does refractory mean? I thought it meant like,
Go backwards.
yeah,
It doesn't?
that's what I thought it meant. Like a reflection though. Maybe that's what we're thinking of. No, I don't know.
Like refract.
But what is it?
To refract.
Let's look it up.
Yeah.
Because I don't like the word and it doesn't help me know what it is. Hold on. Let's just see. Guess I didn't do as good on the SATs as I thought. Oh, this actually makes a lot more sense. Stubborn or unmanageable.
Okay.
That works. I did not know that. I'm going to start using that word. We're so refractory. It doesn't sound right though, does it?
It does.
Okay. But that would make sense for this because like your body's being very stubborn and it's not fixing itself really. Yeah. Okay. So at this point, this is like the MODS death portion is the refractory. Okay. 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 So all of your compensatory mechanisms have failed. Your lactic acid's probably like 8. Oh no. Oh no. What do you think your blood pressure looks like? Stop looking at your papers. Y'all can't cheat your way out of this. Good job. Very, very low. It's like 70/20. Oh, should probably start CPR if you want. So this is where MODS will begin. You're going to start building up in all kinds of waste products. That is called. Turn your papers over, you little cheaters. Turn them over. All of you. Yeah. Yeah. Especially you. Okay. What's it called when your whole body is filled with waste?
Not email.
Yes, it ends in that.
It is email?
Well, it ends in it, yes.
Okay.
Azotemia.
Oh my God.
Ah, you got both of them. So you got azotemia. Okay, so if all the waste products are happening, the kidneys no longer have blood flow. Do you think your kidneys are going to last very long?
No.
No, they done died. So they're going into full out kidney failure. Do you understand? You're in acidosis at this point. Now your body, if your kidneys aren't putting out anything and you're kind of drowning in third space fluid, where's the third space fluid go in the lungs? Fills up the alveoli, and when the alveoli fill, it just continues to fill. This patient's going to go into ARDS. Yes. So now they're drowning in their own fluid in the lungs. Yeah. Oh yeah, that's not good. How are you going to position them? Yeah, you're gonna have to prone them. And then once we get to that point, it's like your whole body and every organ system is going. And what do you end up going into? We already in shock, so don't tell me shock. We already in mods. Don't say death because we're still not there yet. They still kick in. There's one more really bad, awful thing. No, SIRS happened a long time ago. No, it's the thing that usually with like, if mods doesn't get you, this thing's gonna get you. Sometimes faster. I mean, I guess, but it doesn't matter the cause. Like all the causes are gonna end up with, you're gonna go into this thing and it's almost impossible to treat. And most of the time, RIP. Y'all know it. You 100% know it. We've talked about it in here about 82 trillion times. No, that's not it. You know, what's the big, bad, ugly thing? When people get it, you're like, well, shit. Excuse me.
Referring to which organ?
All of them. Every single organ, every orifice, every limb, we're past that. Yeah, what's after mods?
Death.
Usually by this. I'll sit here all day. So.
Cardiac arrest.
Okay.
So you can't treat it?
I mean, you can try, but you can fix one thing and you're gonna make the other one worse.
DIC?
Thank you so much.
Oh
Thank
my
you for
God.
introducing DIC. Yeah, y'all all knew that, did you not? You all knew it. All right, so we're gonna go into DIC, and DIC stands for disseminating intravascular coagulation. So part of your body is clotting and the other part is bleeding. And if you try to fix the bleed, then you're gonna end up clotting. You try to fix the clot and you're gonna end up bleeding, and that's very, very difficult to treat. What was that?
My sock got stuck on the table over here.
Your stock.
My sock.
Oh, your sock. Oh, God bless. Okay. So what are we going to do for this patient? First thing you want to do? Fluids? Always pick fluids. Oh, sorry. No, I'm just telling you like the progression of what it's going to look like. But yeah, you can try. Fluids, pressors.
Maybe I'll be.
What are your options for pressors?
Epi.
Epinephrine.
No
Sorry,
epi.
I'm so sorry. Norepi, DDAVP, or vasopressin. So, but
Phenylephrine.
oh, phenylephrine. I wouldn't use it in ICU. You're right. It does vasoconstrict, but we may or may not use it. What's the other two big ones that we usually use for systemic vasoconstriction? It vasoconstricts so well that you can actually lose a limb. I didn't taught y'all this in farm.
Dopamine?
Yes.
Butamine?
Yes, both. Dopamine and dobutamine. Yes?
Mm-hmm.
Okay. I would more use dopamine if they're in what type of shock? So anything except cardiogenic. What's the one that we would use for cardiogenic?
Butamine.
Dobutamine, because remember that one works more on
Contractility.
Hypovolemic. Yes, you could use it for hypovolemic. So pretty much all of them, because it has systemic vasoconstriction, right? But the one that we specifically use for like CHF exacerbation, cardiogenic would be dobutamine. All right. So their kidneys are pretty much, so what are we gonna do? We have to fix them, but dialysis, we can't continue them on. There's something else that we're gonna do. Because dialysis is like you do it for like 4 to 6 hours and then you pull them off. Well, I need something like going. CRRT. What is CRRT?
Continuous renal Replacement therapy.
Continuous renal replacement therapy. It's like a continual dialysis we can do in the ICU. So now we're going to clean that out. So that will help with the azotemia problem. Yeah. It'll help us a little bit with the fluid balance problem. Yeah. Okay. So that'd be fun. And then if they had gone into mods and they got to the point where liver starts failing, what will that patient look like?
Yellow.
Okay, maybe, but what? You know, this is happening like usually very acutely. So they're not just going to some like glow like a fluorescent light bulb. So all our liver patients itch and all our liver patients bleed. Thank you. So this patient's going to start bleeding out their nose, which is called epistaxis. Good job. Epistaxis. Yeah, you got it. They're going to start bleeding out like in the urine, in the stool. They're going to start vomiting blood. The rectum is just going to start oozing blood. They're going to bleed everywhere. What do they need to be given?
Fresh frozen plasma.
Boom. Fresh frozen plasma. Huh. Yeah.
Yeah.
Okay. And then we need to watch their coags because I need to watch and see if they're going into DIC. Good job. We understand the progression. Compensatory progressive refractory. We feeling good? Good job, everyone.